So without further delay, our first speaker is at @JWhitfill on Twitter, Dr. Jim Whitfill from Scottsdale Health Partners.
Thank you, Tom, for that very kind introduction. So it's a real pleasure to be with you all here today. It's actually not a pleasure to be here today. I'm only here because I was shamed into presenting at the last minute by my good friend Andy Strickland, who promised that he would present if I would present. So I have no slides, I have no prepared talk, so I'm going to give you, though, a 5-minute quick chat about the intersection of radiology and value-based care. So as many of you all know, I am an internal medicine physician by training. I did a fellowship in medical informatics. I worked with a very large private practice radiology group in Scottsdale for over 12 years. So I deeply understand the volume-based healthcare world of radiology. But in the last 4 years, I've also been the chief medical officer for an accountable care organization. So a lot of people come to me and they say, Jim, you've been in these two worlds. What's the future of radiology look like with value-based care? So I'm going to give you two quick, perhaps worthless nuggets of information. The first one, though, is what's going on in value-based care today and how does imaging fit into that? So the simple way to think about value-based care is that you start getting reimbursed or you start getting paid not just for doing procedures, not for taking doing an MRI or doing an endoscopy or doing open heart surgery, but you actually start to get paid to take care of a patient. But if you spend more than you originally got paid, you're just having to cover that yourself. Or if you spend less than you were originally paid to just care for that patient, you actually have a profit. So early phases of these type of value-based care tend to be incentive programs where I'm still getting paid fee-for-service, and this is how the Medicare ACO programs work. You still get paid fee-for-service, but then at the end of the year, you calculate actuarially maybe over 1,000 patients or 10,000 patients, i.e. your population. And if your total spending for that population was less than the statistics said you were going to spend, then you had savings. You actually get a check back for some of that. If it is more, depending on the program, you either don't get anything or you might even have to pay Medicare back some money. So if that's sort of the beginnings of what value-based care looks like today, and in a future state, it will probably look a lot like what's going on at UPMC, like you heard Rasu talking about this morning, where you have healthcare organizations and integrated healthcare delivery systems begin to also have payer functionalities with them. So in that model, Boeing might go to an employer, which they do, and they might say, here's $500 for every employee, and we've got 10,000 employees, you can do the math. You got to care for that whole population for the next year. And if nobody needs liver transplants and nobody needs knee surgery replacements and whatnot, you may care for that population for less than that amount of money. If there is a lot of bad events, you may end up costing you more than what Boeing paid, and you have to make up the difference. Learning how to do that is very difficult. So we're in the process of trying to just begin the analytics processes, the care processes to figure out how those work. So Steve Horney and I were talking about this earlier today, and the beginnings, I will tell you today, in most Medicare shared savings plans and these early value-based plans, imaging really doesn't play much of a role at all. Not to upset you, it actually should I'll tell you why I think that's actually good news. Because we don't even know what's the value of imaging. Does imaging prevent readmissions? Does imaging prevent deaths? Does imaging prevent readmissions? Does it prevent ER visits? Those are the kind of hard facts or the hard outcomes that people are looking for. So in the interim, what's happening with radiology today is this idea that, well, we'll look at how many MRIs, CTs, and PETs that you're performing, and we'll use that as some sort of utilization measure. So what that means is there's an opportunity right now within the radiology space, and I'll challenge each of you all to think about this very hard problem. How do we, as a community, prove our value beyond simple things like turnaround time or peer review, recall rate, or things of that? How do we begin to associate the value of imaging with hard outcomes like death, total medical cost, avoided admissions, avoided ER visits? Because whoever figures that out will be quite valuable indeed. And so I'll leave you with a vision for where radiology could be in the future. Today, in a volume-based world, radiologists are trying to read as many studies as they possibly can. That's how they make their living, and there's tremendous investment. It's very distracting because I know there's something up on the screen here, and I don't want to turn around, and it's Tessa, making me look bad here. and whoever's live periscoping this is really going out, so I'll catch up with that. But anyway, this is the downside of dynamic interactive SIIM environments. But so I'll wrap up by saying in a volume-based world, I've got to know what that is. Oh yes, that's very good. I'll be announcing my election campaign coming up. Am I out of time?
You're out of time.
All right.
Thank you, Jim. All right. Thank you, Jim Whitfill.